See me means it is good.
Okay, we
How are
have
you
we
doing?
are
Where
on
are you
live now.
now?
मैं मैं बैंगलोर में
Yeah,
ही हूँ और कहाँ जाऊंगा यार।
we are on live,
Yeah,
I
we
think.
just
Right, we
started
just
it.
started the live broadcast.
ओके।
Um, right. So to begin with, hello everyone, and I extend a very warm welcome to all our panelists that are present with us today and all our viewers who have tuned in. I, along with Rashna Aravind, are your moderators for the day. We are both interns at TherapHeal, an online platform that provides evidence based mental health care for clients and professional development programs for mental health practitioners. TherapHeal, founded by Dr. Ananya Sinha, is a team of 15 clinical psychologists striving towards clinical excellence, compassionate care, and professional integrity. The aim of our organization is to make quality mental health care accessible and available to all. Today's panel discussion, titled At the Edge of the Lifeline: Understanding the Psycho Legal Nuances of Mental Health Emergencies, is an attempt by our team TherapHeal to shed light on the complexities of dealing with emergency situations such as suicide risk management, abuse, and self endangerment. As a trainee counselor myself, I have often come across questions about how to navigate these emergency situations when they do arise. And with the COVID 19 pandemic and its adverse effects on mental health of citizens around the world, mental health professionals too have witnessed a rise in such complexities. Today, we aim to bring in some clarity on these topics from a psychiatric framework, taking into consideration both child and adult populations, and also learn about the legal aspects. For this, we have eminent psychiatrists as our esteemed panelists today, and I'm very honored to have the opportunity to introduce them to you. First of all, we have Dr. Himendra Singh, who is presently working as an assistant professor of psychiatry at MS Ramaiah Medical College and Hospitals, Bangalore. Sir has completed his BSc, MBBS, and MD from NIMHANS, Bangalore. Dr. Himendra has vast experience of nearly 13 years, especially in the areas of suicide prevention, emergency psychiatry, de addiction, and psychosocial rehabilitation, among others. Sir has expertise in dealing with adults with psychiatric conditions. He has received numerous awards and accolades and has over 64 publications in both national and international journals. Sir also holds membership of the Indian Psychiatry Society and World Association of Psychosocial Rehabilitation. We are very pleased to have you here with us, sir, and we welcome you aboard.
Thank you for me with you and congrats to this platform. We are all together and we will all also wants to share what we can contribute.
Thank you so much, sir. Yes. Next, we have Dr. Raghavendra Kumar K, who is a full time private practitioner and the founder of Man Mandira. Sir has completed his MBBS from VIMS Bellary, MD Psychiatry from Goa Medical College, and Doctorate of Medicine in Child and Adolescent Psychiatry from NIMHANS, Bangalore. Sir has over 11 years of experience in child and adolescent psychiatry and is one of the very few super specialist child and adolescent psychiatrists in our country. He has remarkable expertise in diagnosing and working with developmental delays, behavioral and emotional concerns, and neurodevelopmental disorders in infants, children, and adolescents. He is also among the very few child rights advocates, along with being a practitioner, and has done a postgraduate diploma in child rights law from National Law School of India University. Sir also holds several publications and memberships under his belt. Welcome, sir. We're very delighted to have you with us today.
Hi, good evening. Hi, Heminder. Hi, Vandana. Hi, Zainab. Hi. Yeah. Thank you for the kind introduction. It is a pleasure to be a part of this platform to share and spread knowledge and learn new things as we go along. Thank you.
The pleasure is all ours. Sir. Thank you so much for joining us. Finally, we have Dr. Vandana Shetty. Ma'am has also been with us previously. So, welcome back again, ma'am. Ma'am is a psychiatrist and rehabilitation specialist with 8 years of experience as a specialist in the field. Ma'am is a consultant psychiatrist at Nirvikalpa, the Mind Body Center. She has completed MBBS and Masters in Psychiatry from Rajiv Gandhi University of Health Sciences. Ma'am has also undergone additional training and earned a fellowship in psychiatric rehabilitation from NIMHANS. She has expertise in the areas of addiction psychiatry, adolescent psychiatry, sexual medicine, rehabilitation in chronic mental illnesses, and promotion of workspace mental health as well. Ma'am has a background in working with both children and adults and emphasizes especially on women's sexual health as well. And she actively works towards normalizing the dialogue around mental health and promotion of overall mental well-being. She is also a member of Indian Psychiatry Society, International Society of Sexual Medicine, and Royal College of Psychiatrists, UK. We welcome you on board, ma'am.
Thank you very much for this warm welcome. I think it's a really great idea to put this together and share experiences, especially of managing emergencies in an online platform. Thank you for having me.
Thank you so much. Now, to begin our panel discussion, I welcome my co-moderator, Rachna Arvind, to start off the discussion.
Thank
Thank
you,
you,
Zainab.
Zena, for the warm introduction. We would like to start off with this discussion by addressing what we're here to talk about emergencies and how do we handle these emergencies as mental health professionals in the psychology field. For this, I would like to invite Dr. Hemendra to give us a brief of how, in his area of expertise, he defines emergencies.
See, my area of expertise, very beginning, the time I have joined Nemans, I was told emergency for psychiatrist is harm to self. If clients is engaged in harming to self is an emergency. And same way we have seen in short stay ward where patients were brought forcefully because they were violent, dangers to others, and that was perceived emergency. And we were trained how to deal with this. But over period of time, I learned with experience how it is important to evaluate suicide risk. It could be imminent risk or short-term risk, and based on various other factors, you can divide mild, moderate, severe, or high risk. So for me, because I have done my MD thesis, it was I think first kind of thesis in immense those days. People used to ask me, "Are you taking this area? Are you serious?" So because I was not aware what to do, so I was told one of my senior residents, "Ki better you take this area, and you will get many clients having such problem." And since then my journey started, and subsequently I joined Ramaya Medical College, where I got an opportunity to work with suicidal patients. And during pandemic we were able to do some kind of assessment because in person visits were not possible, but we were able to run a project where we have developed a 3 sessions suicide prevention module. Just 3 sessions after crisis management and medically patient is stable. And we have taken a project for leadership, and we were able to translate this project into formulating a suicide prevention clinic at Ramaya Memorial Hospital. And so we are running that clinic, and every week we get clients, they come with distress. So I will talk once this discussion goes on to share my uh, learning, which I learned through my clients, and I'm very thankful to these families giving consent and allowed us to learn through them. And we have helped during 6 months follow up during pandemic. We used telecommunication to know their warning signs. Are they recovered, or there is risk is persisting? As you know, once it comes to suicides, invariably 90% of clients are suffering from one or other mental disorders, which is published by WHO, that report. And risk assessment for suicidal patients, basically understanding what is the underlying mental illness. It is not just behavior. In DSM-5, we consider non-suicidal self-injury another dimension of self-harm, where further research is required. And even my thesis, we found that non-suicidal self-injury frequency was an independent risk factor for suicide attempts. If you engaged in, let me clarify before going what is non-suicidal self-injury. It is not suicide attempt or suicidal behavior. It is an intention to hurt him or herself without intent to die. Here, very clear cut demarcation. There is no intent to die. It serves many functions like dealing with frustration, seeking. People have myths. Those who hurt themselves may be like stigma. They are suffering from mental illnesses, but this is not the case in all cases. It serves many functions to deal with underlying anxiety, anger. Something is wrong within me. They don't understand what is going on. If you see, lifetime prevalence of non-suicidal self-injury is nearly 4%, and commonly it is seen in adolescents population. I think Raghavendra can comment later. Nearly 15% adolescents are engaged in such behavior, like they use many methods. Cutting is seen commonly. There is no such men and women difference, gender difference, but only difference we found in the method they choose, like commonly used, like cutting, overdose pills, banging their head. So across culture, we have found differences in the method they use, but if you see, frequency is same. There is no gender bias when it comes to self harm. But definitely we have neurobiology, gender based neurobiology once it comes to suicide. Suicidal brain is not as the brain which is suffering from psychiatric illnesses. It has different neurobiological substrate and neurocircuits and battery of biomarkers. And there is role of many factors. So suicide risk assessment basically collecting the information what are protective and risk factors, and then to know what is short term risk, like online counseling you are doing. What is short term risk? For that we do suicide risk formulation, where you understand how these factors interact to each other, which buffers which, because there is no such thing how many suicide risk factors are there and how many protective factors are there. Could you substrate could you get net suicide risk by knowing protective factors or risk factors? Which risk factors you want to give more weightage and which you want to give less weightage? There is no such thing. Even in emergency setting, we have many risk assessment tools, very familiar, like suicide intent scale, suicide ideation, back hopelessness. There are many, more than 1920 suicide risk assessment tools. But these tools, as per nice guidelines, you can't say which respecter will contribute what. Suicide risk is a dynamic process. Many times client may be having suicidal ideations, but client is in denial. And there are many reasons they don't open up, like therapeutic relationship repo. Basically, once you see online interaction, it's not easy to open up. Problem in internet, he's not understanding your language. Maybe cognitions being distorted due to underlying psychopathology. Comprehension is not intact, and losing autonomy once it comes to online consultations, or fear of losing job, or person can say I'm making anxious my therapist, better to not disclose these thoughts. So these are few challenges. It's not about challenges at online consultations. Even offline, person is brought to emergency And you see the way we have designed emergency uh, ward, like I work in medical college, where emergencies are life-saving emergencies. In psychiatry, suicide is one of those emergencies. But confidentiality, private room to do, uh, counseling involving family members, clinicians are not trained. Those skills, training is not being given to them. Sometimes they react in shock, like family does that initially. What went wrong? And waiting list there. Once it comes to psychiatry, like you are stable, having just suicidal thoughts, initial treatment was given at local nursing hospital. Then you are in waiting list because they will attend someone had fracture, massive heart attack, other uh, uh, life-saving problems. So once it comes to emergency, even you give initial treatment, most of 70% of clients, they leave emergency ward without any risk assessment. This is I am talking about published research where psychiatrist was not involved. And many times risk assessment, if you see, it's not complete, poor. And many people are engaged there. It's not just you just came, you did risk assessment. And communication between professionals, you have to tell this risk to nurse, family members. You have to write safety measures, 24 hours, one attender, remove all sharp objects, pills, bed sheets, right? These things, such things should not be in close contact with client if risk is imminent. So how to know that? You should know person is suffering from some diagnosis. Like you do online consultation, first telepsychiatry guideline which is available to everyone. So without knowing diagnosis, moving into therapy is not good. At least provisional diagnosis you should be aware. That is important. Gender, once it comes to suicide, female, male, what are resources, protective factors, future suicide attempts, future, like sorry, past suicide attempts, past history of non-suicidal self-injury, worst point in their life, that point, suicidal ideations are more correlated with imminent risk rather than current suicidal ideations. So these things should be inquired. Family history of suicide, it gives clue regarding, genetic vulnerability. We believe in stress diathesis model of suicide. Just stressors are not enough. There are two way of thinking. People believe first person may be suffering from depression. So while you are depressed, you tend to get into problems because problem solving skills deficit. And brain areas like dorsolateral prefrontal cortex overactive, uh, like orbitofrontal cortex overactivation, poor number of choices in making decision. And that happens because of low level of serotonin while you are depressed. So there is little understanding about stress diathesis model. Just having NSSI doesn't mean person should be perceived like suffering from childhood trauma. These are myths. It could be just behavior, impulsive act, may not be any sign of any psychiatric illness. Sometimes it happens. So, but it raises many issues. MLCs should be registered in hospital because you don't know it's a psychiatric illness or sometimes it's just something else. As I said, what about 10% suicides which are happening? Any MLC is involved in that. It's better to document everything. So coming to there are many things. So we have come up with online, at least reaching out these people, and we appreciate Mental Health Care Act, where Section 309, that was kind of barrier seeking, you know, fear of punishment. That is another stigma, as if I'm a weak person. So many times you don't disclose even you are a suicidal. I think people, those who are attending, are okay, because we are talking something which is not usual talk, but people are hesitant to ask. Very important thing in suicide risk assessment, asking what to ask. Like first consultation, family members are with client. Client is not disclosing anything. A few weeks back, self harm, seeking help online. What to ask? Will you ask directly, are you suicidal, or is it causing some kind of any iatrogenic risk? Giving such idea, am I making him suicidal? This is not the fact. Dozen of published articles proved last few decades. Talking about suicidal ideations to the subject or client is not giving any clue to get into suicidal behavior. So we should ask directly, are you having suicidal ideations or any plan to carry out? What was past history? Do you want to tell me little more about it? Oh, so are you having any mean to carry out with you this? Did you take any precautions against discovery? Are you collecting pills? Directly ask. In fact, it reduces suicide risk because you gave an a platform to talk about it. He's just waiting. Someone should talk. Then you have to work with client. There are do's, don't. No need to preach. You have many things in your life. We get into these thing in emergency department, untrained professionals preaching about morality, this or that. No need. Listen. Allow client. Be empathetic. Your body language, eye to eye contact. Platform is this online is different. I am talking while we go in person consultations. So you have to write down diagnosis because it is an emergency and we work under Mental Health Care Act. If there is an emergency, you did assessment, better to refer such client to nearby hospital. Encourage them to reveal their ideations, help them with their friends whom they trust. So it's very important. It's therapeutic too, and teach them basic skills. Most of the times they, you know, like we do narrative interview initially. We teach them just start with breathing, then society related cognitions, problem solving skills, maintain a logbook, and third session we involve family members. Individualized safety card we prepare, A4 size paper we cut into four. So we use for person can carry in, if I am suicidal, what I have to do. Give a pause, watch your breathing, watch your cognitions. It is just passing thought. Contact nearby therapist or friend or nursing home or suicide prevention clinic. What has helped you before? Work on that. And warning signs. It's very important. Individualized warning signs. Again, you are engaged in reckless behavior, anger, right? Life has no meaning. People have lost their loved one. We have seen families where two people are not there. One person is running the show. Mother is on dialysis. Daughter has to work, who was in college. So there are cases because earning member is no more. So we should be very sensitive to these clients. They need regular follow-ups, and we need assertive follow-up once it comes to suicide attempters, that we call tertiary prevention. Secondary prevention is what you do, identifying underlying psychiatric illness if it is there, and treating diathesis. We use, SSRIs, ECT. There are therapies like CBT. You people are expert in that. I should not talk about it. So one is suicide. It doesn't see pediatric to geriatric, all age group. If you see a data national crime bureau report is shocking. Cases are increasing. It hurts many people. One suicide hurts many people. So one suicide attempt, there are behind that there are many people having NSSI, underlying depression. There are potential clients because it's a random thought. Anytime it can come, right? No one wants to die. All suicide attempters, they want life, but not this type of life. So once we work on protective factors, I think it's not psychiatrist responsibility or psychologist responsibility. It is responsibility of everyone, all citizens. We are few human beings in comparison with other creatures. We have to take responsibility. We have to work together. What we have created around, right? We can create such vibe. So now paradigm shift, rather than talking risk factor, fine. Like cardiologist says, yes, you have to take care of your diabetes. He's right to prevent mortality due to stroke or cardiac uh, problems. He is right. Same way, if we talk about anxiety, depression, uh, other psychiatric illnesses, I think we are right. Mental health is equally important. We have to generate more funds, more such, rather than doing any assessment. Some assessment should be done online. It's a dynamic, even formulating guidelines. These are guidelines, right? We don't know future. Only we will be all in such platforms. It is required, easy to reach out, and it takes 5 minutes. Past attempts, family history, resources, underlying psychiatric illness, how many protective factors, no protective factors, many risk factors, admit immediately. And there are problems, continuity of care, right? Immediately patient wants to go home. Patient doesn't know where to come for follow up, whom to meet later, right? So it's important to, even after discharge, engage psychologist. If there is underlying personality disorder, family discord, marital discord, you people will serve a lot. So once patient is stable, understood all steps, later on refer to treat underlying problems in communication, relationship. Most of clients say this is the problem. I want life, but not this. Who wants to go away from this beautiful life, right? So this little insight is enough. And other emergencies we see, as I said, violent behavior, intoxicated patients come, substance abuse. They may come intoxicated, withdrawal symptoms like delirium or other symptoms, and other risk factors like personality disorders, antisocial personality. People were caught by police and brought to emergency sometimes. We can't help that time. Later on, we call them follow up. So there are many emergencies. We are aware. I think you can move forward. Uh,
Yes,
I can go on talking, but I think we have to learn from others.
of course. That was very informative, sir. I mean, all the information that was coming in about injuries and risks, and we've got so much insight already. I think I would ask Rashna to take the discussion forward and move to the next panelist.
Okay. Thank you, Zainab, and thank you, Dr. Dinendra. It was wonderful to hear from you about the different aspects that you have seen and through the years of expertise. Um, Now that we have an understanding of what these emergencies are that we could potentially be talking about, I would like to invite Dr. Raghavendra to tell us a little bit about the legal aspects that we as psychologists face in such situations. From your expertise, sir, please. Sir, you're on mute.
Yeah, sorry. Um, I will stick to the legal aspects solely because I don't want to make it too lengthy as well. And see, when it comes to legality, uh, it's always black and white. Okay, but in medicine, it's not like that. So in medicine and in life sciences, it's completely different. And legal issues are always black and white. That's the first thing we need to remember. What the judge or the lawyer or the magistrate or whoever of the police, what they say is a circumstantial evidence. Okay, so from our side, what we need to ensure as practitioners is we have covered grounds very clearly, like in terms of documentation, in terms of, like they say, no, the documentation, the communication, and the documentation of the communication. So these three things are very essential wherever it is. Okay, so that is very important to save our skin, because many times you don't know. See, the cases which would have seen 2 years back, 3 years back, especially the speed which Indian legal system has, they come back to bite us 5 6 years later, and then we will be totally stumped. We are totally like flabbergasted. What was it? When did I see this kid, and when did I see this fellow? So the point is, um, having very meticulous documentation, and beforehand, communicating the same to the person that there will be documentation, and uh, it might have to be revealed to concerned authorities whenever there is a uh, legal implication, and you're bound by law as well, right? When a court asks for a document, you cannot say no. So that way you are bound. So that is the first thing. So you have to be very, and always see, I don't mean to induce paranoia when I tell that, but any case can turn, there always keep a uh, scope for case turning legal. There might be some legalities coming up later on, so always keep that faculty in your mind running parallelly in every step of the case. Like something emerges in, say, in the middle of, after 10 sessions you find something new, then there might be a legal turn which it takes. So always every session always have that faculty, one small faculty of your mind thinking about what legal issues might, and you don't have to fuss and finick about these things endlessly, but you have to be a bit mindful of these issues. Okay, and um, in terms of again legal issues, see, you want me to talk about the under 18 part and the above 18 part, the adult
Sure,
and the
sir.
childhood issues as well,
Yes.
because again it's a complete different ball game when it comes to children, especially because See, and up till 18 world over, except in Somalia and USA, the definition of child is still is 18 world over. Okay, literally only two countries, Somalia and USA, they have their own definitions. That's different because they have not signed the UNCRC. That apart, the definition again, while dealing with minors up till 18, so even if it's 17 years and 364 days, that kid in front of you is still a minor, and parents are the legal guardian, whatever the case may be. Okay, and so with that, the question of confidentiality does not arise in terms of, like, say the child is suicidal. Just to take what Himendra said and taking it forward, um, say a 17-year-old kid is a boy is suicidal, and he doesn't want you to reveal because he's scared of his parents' reaction. How will we deal with it? Ethically, now we might want to delay one or two, like, or maybe that kid revealed he had attempted suicide 2 months ago. Parents did not know. He had strongly contemplated suicide. He had bought a pesticide and had kept it, but then later on discarded it for some reason. So in these cases, there is no gray zone. There is a clear cut black and white zone. Okay, you have to reveal it to the parents, and the guidelines do not say that when are we supposed to reveal it, but as soon as possible, take the adolescent or the child into confidence. And most of my experience, no, they will agree, they will not deny, they will always tell that okay, you can reveal it within one or two sessions. That can be done. Okay, like I'm currently seeing one girl who is 17 and a half, and I'm seeing her twice a week because she is suicidal as well. And uh, and parents were not, I mean, aware, and then after taking her into confidence, she kind of agreed uh, to tell about these things to the parents. So the most important thing is, parents are the most biggest stakeholders, whether you agree or not. So here we are in two divergent views. The as a the therapeutic alliance, the first we would want to think about the therapeutic alliance as a therapist, the first thing. But legality will again make a, the judge will not ask what about therapeutic alliance. They will not understand the head or tail of it, or the police. So again, the communication, the documentation of this is also very vital. Okay, and that is the first thing. And there are several other emergencies which we also see. Do you want me to touch on that as well? The emergencies like
Sure, sir.
sexual abuse, which the kid revealed to you and nobody else is aware. So not just kid, even adults also, if they reveal, then and so again, so that is again a much more tricky territory. So again, um, sexual abuse. See, again, there is no way you should you can hide it up. As a caregiver, you are supposed to reveal it. It's not just caregiver. Even if somebody else gets to know that that one somebody has been sexually abused, one kid has been sexually abused, then it is supposed to be revealed to the appropriate authorities. And you are legally bound to do it. There is no way out of it. Okay. It's as simple as that. If you ask in black and white, then you have to reveal it. Okay. The modality, the time, when will you reveal it, all those things, there is no clear cut guidelines for that. The lawmakers have intentionally left it a bit loose, but they cannot prescribe the modality. Like, see, in some village, some remote village, there is nothing, no access, and you still get to know, you still have to report it, right? So they have left it intentionally. So what can be done as an individual standalone practitioner? If you are in a hospital or if you are in a college, then it's easier. You will have all the team and medical superintendent. There is a clear, proper channel in place. But if you are a standalone practitioner with a clinic and nothing else, then writing a simple letter and having an acknowledgement due for that is also sufficient. Whether the concerned authorities open the letter, they throw it into the bin or anything, that's not our job. I don't mean to be insensitive in this case, but the point is covering legal ground is very important. Okay, because there are cases where for whatever reasons it doesn't get escalated and parents themselves don't want to escalate it, and but you as a care provider, you are bound by law and you have to provide, you have to escalate it. It has happened to me as well. So parents are totally, many times parents are totally antagonistic to it. They will not want to report it, but you are completely bound. So the question of not wanting to report does not arise. Yeah, when to report is in your hands, but sooner the better. Okay, and there is a huge risk of the therapeutic alliance going completely for a toss in this situation. That is a part of your daily bread and butter. You just can't avoid that. It's fine. When it comes to legality, morality, ethicality, everything goes out of the window. So you are bound by law. It's as simple as that. Okay. So that's the most important thing. And coming to other areas like see, a child using substances and the parents are unaware. They that can be kind of we can buy some time until the kid is completely on our side. Then we can kind of talk about reporting and not reporting, rather. Even in this case, if the kid is in some other risk, then we have to report it to the parents immediately. And the most important thing which we need to see is, while dealing with an above 18 and while dealing with a under 18, the most important thing is above 18 there is only one stakeholder, that is the client. Under 18 there are several stakeholders. So that is the bottom line of this thing. And the several stake and many of their interests may not be aligned properly, and many times it's at cross purposes. Okay, so it's completely in cross purpose. Like parents want, the kid wants it to be reported because the sexual abuse, the abuser, the perpetrator should be punished, but the parents don't want the kid to go through several things, and they are ashamed of the kid's future, and there's several things. They are all worried. So, and you also want to report. So again, and then government also wants you to report. So there are several things which you have to consider, and legality always takes precedence over everything else in this case,
Of course.
in any case. Um, and do you want me to cover the aspect of the court? No, I don't think we should do that. That can be taken up for later. That becomes too
Perhaps we
tedious.
can come back to it later.
Yes, yes.
Yes, thank you so much for highlighting the legal implications and for drawing out the parallels between minors and above 18 people and how do we go about different cases. And of course, there's a lot of complexity involved when legalities come into play. We have slightly touched upon child sexual abuse. Dr. Raghavendra has touched upon that. But we do know that Vandana ma'am works in an OPD setting, and perhaps you have come across, ma'am, across situations of domestic violence or abuse with women. And would you perhaps want us to walk through these experiences that you've had and how do you view emergency in that context?
Ma'am, you're not too audible.
You're on mute, Vandana.
Yeah.
Now I think you can hear me now.
Yes.
Yeah, I think both Dr. Hemendra and Dr. Raghavendra did cover major aspects of what happens, and I do agree that compared to maybe a bigger hospital or a medical college setting where there are protocols in place, handling emergencies in an outpatient setting or as a single practitioner or as a mental health service which is not attached to a hospital but is like a separate entity, all of these pose different challenges with regards to handling emergencies. I think apart from what both the other panelists covered, some other emergencies which may come are like panic attacks or like acute anxiety, or in terms of even with adults, violence. It could be domestic, physical, or sexual violence. All of these being reported on outpatient, we have a different way of handling it. Now, when it comes to any kind of violence or aggression in adults, whether it's physical, emotional, or sexual. I think it is the right of the patient to decide whether they want to make it into a legal aspect. Like, unlike in children, here there is the choice lies with the patient, right? But at the same time, I think it is our responsibility as professionals to encourage their safety and to encourage them to understand the legal provisions that are available to them. So, apart from taking care of their medical needs, also trying to enhance the kind of support they have, trying to increase the education and knowledge they have towards their rights, and trying to get them on this path still continues to remain our responsibility, right? So in that regard, in an outpatient setting, what happens is if there is an acute emergency, it's always very important to have a network. So either have a network of other colleagues who are working in inpatient settings where you could divert them for immediate, that's like acute care. If it is something like something which is not holding an imminent risk to the life of the patient, for example, if it's anxiety or panic attack, which is still very, very distressing to the patient, we could use some SOS medications and ask them to come for more frequent follow ups so that we are in touch with them. Now, in case of something like violence, where let's say there is a imminent risk to the safety of the client or to other family members, like especially younger children at home, older adults at home, they are the high risk category of having secondary effects of violence. Right. So these are also people who would then come under the purview of our responsibility, because if we are getting connected with the patient, then our responsibility extends to all of these other dependent people. And a lot of times in the OPD setting, what has been helpful is to also counsel patients regarding their provisions, also try to connect them with either NGOs or other services which have expertise in these areas. So that because in an outpatient setting, we may not have the entire time to take care and make sure to mobilize all the needs. So we could introduce these ideas and then connect them with different NGOs or setups. Or many settings now also have like a social work team and rehabilitation psychologists and other healthcare providers who may be in a better position and have a better network to support people like this. So it is important to mobilize these resources. We may not be able to do all of it ourselves, but at the same time, having that network is especially very useful if we work in an outpatient setting, an exclusive outpatient setting, or work as like individual mental health practitioners. This becomes really relevant.
Right. Thank you, ma'am. And like we're seeing, we have to mobilize resources, and that's the most important thing for us practitioners to see whom do we refer the clients to, and perhaps there are other suicide prevention clinics. Going back to Dr. Himendra, so we do know that you work directly in a suicide prevention setting, and is there a particular framework for the first immediate steps that we take when a client comes in with, say, to manage suicide risks specifically?
So you're on mute.
Yeah, sorry. Safety of client. Once client either online platform is client is safe. Sometimes they are just calling you. You can't see them. They don't have access to video. So like remote place and you are running suicide prevention helpline. We used to run suicide prevention helpline, and due to COVID, a group of members, NGOs, they were unable to come. Mainly they were volunteers, retired people, and there were restrictions like lockdown and all, but they were helping. So person calls you, I am having mean to carry out uh, uh, right now, and you have to help him. Sometimes this is one scenario. It's not like offline person is walking to emergency ward. So entirely different scenario. And then how to talk. with client? Are you really caring some mean anyone is around you? Could you call somebody nearby? Safety is very important. And confidentiality. Once it comes to suicide, be bound to inform somebody. Ask where is the location, where are you standing? Can I call somebody, right? Or there is nearby any hospital, you can go there. How can I help you? Once you engage in dialogue, so they may stop doing that, right? You can help them in decision making, support them further to seek help. So safety is very important. We have to engage them into dialogue and bring somebody to help them out. They have to move out from that place. That means should be taken away. Emergency, sometimes they may be hiding pills, you can check, right? They may be carrying some means, right? Sometimes these thoughts are random, it comes and goes. Person wants to die, he wants to die. Sometimes person says I can't be helped out, right? He doesn't trust you. He was brought by seeing frequent attempts. Many times we see many clients in a year 700 times cutting wrists, consuming pills, many multiple methods, right? Such clients, even in a week, multiple times, we have to do risk assessment. So safety is very important. You have to assign somebody 24 bar 7. Don't leave such clients under unless they understand what is going around, what is wrong. So safety is important, and that is once you meet client, inquires safety, right? Other things, your consent, where where to refer, come next. Next.
Yes, sir.
Um,
Sir,
I'm
I'm
sorry.
sorry to cut you off, but with regard to what you were just talking about initially, I have a couple of other questions for the other panelists as well. We'll come back to what you were talking about, but with regard to the online setup, I would like to ask Dr. Raghavendra and Dr. Taking clients in the online setup, like you said, if you have a suicide prevention helpline, you're not able to you're not able to see the client. In such cases, if there's an emergency, where are we first supposed to go? What if it's a child? How do we go about that? Could you give us a little bit more information about that, please?
Yeah. See, at the outset itself, before starting an online session, no, it's always good to communicate that there is a limitation, and distance can become a limiting factor in the therapy and the progress. So we have to communicate that at the outset. That's the best way, and that is what I follow. Okay. And there are several sessions. Most of the sessions I usually record with the client's permission. I tell that just like we take notes while we are seeing face to face. I prefer it may be difficult to take notes, but that's the reason I record it. And it will be confidential, it will not be revealed to anyone. And they are and if you are not comfortable, I will not record it. That is what they tell. And then I abide to that. If they're not comfortable, I'll not record that. Okay. But I still maintain notes of what happens in the session. Okay. So that is the first thing. And then making aware of the limitations, making the stakeholders, in case it's a minor, then the parents, and in case it's an adult, then himself and maybe a nearest relative. Okay. And many times it has happened, just like on Thursday I had a session where the girl is in Ranchi, mother is in West Bengal, aunt is in Bangalore, and it was the aunt who asked for a session for the girl without the knowledge of parents, and the girl is suicidal, and she's a minor. So I told the aunt that, see, this is the situation, and there is a risk that she is having in terms of suicidality. So we should bring their parents on board. It would have been a different case if she was with you in Bangalore, because you would have been the guardian for that time. You would have been the legally entitled guardian, but she is elsewhere, and then the parents are the guardians. So there is a clear cut legal angle to this. So she had suicidality. So so like this, so we have to make it very clear. And they have not responded back after that, um, because there are several issues involved, several niceties, several intricacies involved, so to say. Um, but communicating that in no uncertain terms is very essential. Okay, so that's the first thing. Uh, yeah, you want to ask something else? Hmm.
Yes, sir. I just wanted to thank you for that because that is something we all, as psychologists, have the potential of dealing with, right? Parents not giving consent and their suicidality. I also wanted to ask Dr. Vandana about any of her experiences with online setting, or how you've gone about dealing with it in such settings.
Yeah. See, I think online settings are particularly tricky because you may not be in the same city, the client may not even be in the same country. Luckily, we got the teleconsultation guidelines early when COVID started. So some of the confusions were at least put on paper. So there was somewhere that we could go to for guidelines. They're not absolute, and they don't cover every aspect, but at least a major part is covered. So one thing that we were able to follow because of that right from the beginning of COVID, especially is when teleconsultation really picked up, is that the first thing to do is take a consent from the client for online consultation, where your consent form clearly mentions the limitations, as Dr. Raghavendra mentioned. It also mentions every other detail that the client may want to know about what's the duration, what they do. And apart from telling them what the limitations are, also to take an emergency contact from them, and to tell them also clearly that everything, especially with adults, to reassure them that sessions are confidential until and unless the law mandates for the safety of the individual or for the safety of others, that it has to be broken. And in such a case, that the emergency contact would be contacted and informed, right? So usually it is helpful if the consent form also mentions that the emergency contact they provide should be someone who is near them and who is easily accessible, so that I mean, like as Dr. Raghavendra said, right, it's not helpful if your emergency contact lives in another city. So what we insist on is that you give us a contact who will only access if needed, but someone who is close by and who can reach you immediately. And we also explain about what, and you go ahead with the online consultation only if they agree for all of these conditions. And if they write back to you and sign the consent form and send it back, that at least takes care of both legal aspects as well as like our own medical stress of like what do we do in such a situation. And the second thing is, as a physician, when we write out prescriptions, any consultation that I see online, I clearly mention, there's a footnote on every such prescription stating that there are limitations to online consultation. In case of an emergency, please go to a nearby hospital, or please consult the nearest physician. You don't need to wait for a psychiatrist. At least go to the nearest physician, and you cannot, because we may not be accessible to you in case of an emergency. So kindly, like, don't wait. In case of an overdose, or in case of a heightened symptom, or in case of a risk, kindly immediately contact somebody. So these are certain ways where even the client gets to know and has more clarity that this is what they're supposed to do. And just having this conversation with them also reassures them that they're not left abandoned in case an emergency happens. Even if they've met the physician online, they still have a way to circumvent any emergency if at all.
Thank you, ma'am. I think that covered how, in case of an emergency, we anyway give them these other ways if they're unable to reach us or if we're unavailable. Thank you for that. I have another question for all three panelists, and um, anybody can answer this. And the question is, within India, of course, it's now we're after the pandemic, like Dr. Vandana said, we've also moved to the online mode. Let's say that as private practitioners, we're taking up Indian clients who live in another country, right? What are the laws regarding that? Who do we have to report to if there's any issue? Where do we go with that, please?
Can I take that first?
I think
Sure.
client in India is not enough.
Yeah.
International platform is good. There are many mental health professionals. If you see problem this side of world, I think Raghavendra can answer this. I think we have many clients, so we have to follow law here because we are also restrained. Once it comes to life saving, we should not be held for any liability because we are doing in good faith, helping, reaching out. Cost of our sleep, worries, we are saving lives. We should not be held for any liability, even it is India or international. There is International Association of Suicide Prevention. They have a strong lobby now. It is all people responsibility. You should not see boundaries, passports. Who is seeking help? So if you see online suicide prevention, such platforms, immediately that navigates. Are you suicidal? I'm available. It doesn't see where are you living on this globe. So such freedom should be given to mental health professionals who are willing to save lives. We should not come under once it comes to crisis management. I understand safety. If abuse is happening at home, client should be mobilized elsewhere. There are maintaining factors, marital discord, domestic violence, abuse from this side or that side. We live in such society. Abuse at workplace, institute head involved. 1001 things are happening. So once we are involved as mental health professionals, if you want to involve us, we should give a little bit freedom to help these clients because you have developed therapeutic relationship. You are the first contact in their mind and you are asking, I will be not held, anything goes wrong, I'm worried about thousand legal uh, this thing or that thing. I understand, but once it comes to question is life and death, you are looking mental health care act, uh, this criminal act, this or that. Life is life. Later on police is there, law is there. As he said, ki mandatory reporting but not immediate reporting. Once it comes to child abuse, I understand where is abuse happening, who is involved in abuse, then you can immediately report. Like you can think about safety and all, but it's just mild risk. Many protective factors are available because it's a suicide. Immediately go. I will not see. Client was happy with you. So now problem is communication of risk. New psychiatrist has to develop rapport. He has to talk all story to new person. I know online counseling therapy. There are guidelines. You should behave like a this only. Thinking about law behind you, they will knock your door. I think once it comes to life, like someone got heart attack, physician doesn't think about law. We have to say,
That is right. Uh-huh.
agree or not?
Yeah.
When it comes to fracture, people go and take that person immediately. They come and help. Once it comes to mental health, so many law regulations.
A lot of
But I
restrictions.
appreciate mental health act. Uh, this 309 decriminalization of suicide. We should think it's a consequence of some stress unless otherwise proved. We should be given little free hands. Some dynamic changes should be done, right? We don't know. You would have saved that client by the time you take. Eminent risk is there. Person may jump from or throat strangulation. God knows what happens. So I think we should have a strong lobby. Ki somewhere we should compromise in terms of safety, definitely, but not for mild risk. OPD basis follow up, online counseling is enough because suicidal thoughts, refer immediately. Then, because this law guidelines, you can't prescribe medicines which are life saving, right? Such things should not happen once it, because many times we have seen command hallucinations. Just thinking about depression, hopelessness, suicidal ideation is not enough. We have found in my thesis psychotic symptoms, distress associated with psychotic symptoms. Someone is nagging to you all the time, voices, frequency more, loudness of voice, superiority of voice, many factors. Like your mother is telling, COVID enough, you come, this and that. What I'm telling, ki, that relationship. So we have to prescribe psychotropic drugs. Like you should not wait for psychiatrist. Here we
And
don't
I think,
prescribe.
yeah.
Therapist can't prescribe. You have not gone to medical school. I understand. You should given some kind of, platform where you can do
Training, yeah.
parallel degree training, like in other part of world where nurses can prescribe medicines, right?
Right.
Like things are changing now. Things are merging now. Nurses can prescribe basic drugs. So mental health issues should be considered basic needs like air, water, your happiness, freedom to live life is a basic need, not expression. I'm telling life. You express your emotion, there is restriction. But to live life should be freedom, whom to meet. Now things are coming advanced directives. I want only psychologist. Then psychiatrist can't help. He has written advanced
Yeah.
directives. I should be treated by Dr. Purnima in Indranagar. And Dr. Purnima says, oh, I can't write medicines. And it's as per teleconsultation guideline. I don't have clinic, I practice online. Though I have helped you in many situations. But now you are suicidal, you have to meet some other psychiatrist.
Yeah.
It hurts. It hurts.
That is very challenging.
The person who is available is not help, can't help because of law.
Right. And we do agree
Safety.
that
I'm talking
perhaps, yeah.
about mild risk. I'm not talking about
Yes.
moderate risk where you need 24 hours observation, or high risk where immediate ICU admission. Person is expressing death wishes. Person have protective factors, many. Something got stuck in mind, like breakup, uh, teacher didn't give proper feedback, upset with head of institute, not taking what she or he supposed to do. And is a mild concern and you are suicidal and sorry, could you hear?
Yes, sir. Yes. Please
Someone
go on.
muted
We
me.
could hear.
Anyway, I don't mind. What I'm telling, mild cases. Once you did risk assessment, risk is mild. There at least little compromise. Psychologists should be given free hands. Though you are documenting, you ensured, safety. Bhai, every suicidal ideations, mild risk, not attempted. I'm telling suicide, 2.5 lakh people die. Attempters are 25 times more than those who have died by suicide. Nearly 50 lakh people attempters. Once it comes to NSSI, my God, you can't. No data are available. So what I am telling, such cases, NSSI now you are confused is a suicide attempt because just seeing cutting wrist or refer immediately. It may not be suicide attempt. Everything is not suicide attempt. It just person wants to express emotional pain into physical pain, doesn't want to die, and seeking help for emotional pain, not for wrist cutting. Patient doesn't talk unless you ask, do you have cut marks? And once you found, oh my God, cut marks today only, fresh, refer immediately. It is your client, you have concerns. So in such cases, I think we should have discussion with stakeholders. We should give data for policymakers. We should do proper research. Large scale epidemiological studies should be sponsored by government funding agencies to carry out such research. We do research side effect of psychotropics across India because it is sponsored by vested interest of pharmaceutical companies. Whatever, once it comes to counseling, suicide attempts, NSSI, right? Funding is very less. I mean, seeking funding for such research, you have neurobiology, some receptors, genetics. Definitely, someone will give you funding. Once it comes to saving life counseling, 3 session counseling effectiveness across India, multi-central study. There are people; those are generous, but we should also work hand in hand, find out such stakeholders. So once it comes to mild cases, definitely free hand should be given. We should
Yes, sir.
request to stakeholders.
Mhm.
So you people should be happy. You should talk about it, but proper documentation, safety, because you are bound to all liabilities as per Mental Health Care Act. If you are
Yes,
mental
sir.
health professional,
Yes, sir.
you are aware and you are doing in good faith. We should not be worried. Thousand things about once it comes to life, mild cases. I feel go on doing counseling as long as repo is good, involved
Yes, sir.
family, friends. Safety is important.
Yes, sir. Thank you, sir. I think it was very valuable to know your opinion on how we should approach seeing overseas clients as well. There was a question in the chat that came up regarding to this. The chat says, I was unable to stay tuned continuously, but something I'd like to understand is what are the things we need to take care of exactly when we're seeing overseas clients because I'm starting off with practice, especially if they show up in a crisis. What are we supposed to do? So, for the other two panelists, you can pick that up and Dr.
Please take it
Raghavendra,
up,
please.
Vandana.
Yeah, I think overseas clients is something in private practice we do see quite a lot of. I think in private practice, especially in outpatient settings, a lot of approach has now started off from overseas clients, especially because of ease of access, affordability, and I think the waiting time is much lesser if they're approaching India. And I think a major chunk of overseas clients are non-resident Indians.
Expats.
Yeah, expats are like the major chunk of your overseas clients, and I think the waiting period comes down from weeks to just hours to days when they access. But the challenge, I think, is about if they require medications, how do we prescribe it? How do they access it from there? Each country has its own rules. And also, with regards to the kind of support. For some countries, what I have found has worked is if we do an assessment and are able to provide a recommendation letter to the GP of the country that they are currently residing in. stating that we have assessed and this is our observation and this is our recommendation, and if they could just support the client's needs. That does the job in many, many countries. It may not work in all countries. Some people who might be frequenting India may prefer that they get one of their relatives to either source the medicines for them, or if they are like closely placed to come on a visit, carry medications. With that, I think we have to be mindful that there are restrictions for carrying certain class of medications to certain countries. And even though it may not be a part of our routine practice, sometimes it's just helpful to check on Google regarding like the country that we're prescribing to, other restrictions for certain medication classes. Just makes it easier. Otherwise, the client may at the customs and at the immigration clearance may have some trouble. And the other alternative, as I said, is to just keep in touch and network with their GP or their mental health provider in the country of choice. Now, when it comes to therapy, I think, of course, this challenge may not be there. I think the major challenge in seeing overseas clients is matching timings and matching the kind of time that we're able to give, etc. So I think that is the major challenge with therapy. But even in that situation, if there's a crisis, what again, I would say that I use the same policy. I ask them who they stay with. I mean, like, for example, if we're seeing students, they may not actually be staying with a family member or relative. They may just have roommates, right? So if we are looking at roommates or friends, like, do they have a trusted member who can support them if there's a crisis? Is there a hospital nearby? I think, at least in the Western countries, accessing emergency crisis management for mental health care is much more developed. It's much easier than in India. Like how Dr. Singh mentioned, that maybe here our triage will give priority to fractures or heart attacks versus suicide risk. But I don't think abroad, at least in the Western countries, this is not a problem. They have well established emergency care. Where I think the trouble is that after the acute management, actually getting in touch with the psychiatrist or the mental health professional takes some time. There is at least a few weeks of gap. And I think most of the people also, because of the transcultural differences, prefer to meet someone of similar cultural backgrounds because our understanding is better. So trying to use the local resources like friends, roommates, if they have relatives, use the help of relatives. And even if they are continuing to seek mental health guidance from us, still keeping their GP informed that this is what we have as an observation, we can just provide the letter to the client. If and when a situation arises, they can use it. I mean, not that they don't need to go and give it. So that has been found to be quite helpful. And I think this is one way in which we can still support overseas clients even though there's a physical distance.
Thank you, ma'am. I think you covered a major aspect of how we can bridge that gap, even when the gap is sometimes huge. Right? Dr. Raghavendra, can you please tell us a little bit about the legal aspects that you wanted to add in initially as well?
See, Dr. Hemendra brought up a very valid question and a very pertinent question. It's about like doctors without frontiers, doctors sans frontier. That what they say. Humanity comes first, then comes morality, ethicality, and then legality. Because legalities keep changing. Cannabis was contraband, made contraband 100 years ago, and now they want it to be legal. So legality keeps changing, but that is where we get stuck. And legally, what the Indian government says is that we are not supposed to prescribe medications to online clients, and there is no set guidelines. I mean, I spoke to the registrar of our council also. He said there is nothing which we will not tell you not to uh, prescribe. We will also not tell you not to. So it's basically there is no clear cut guidelines, and it's completely like you're by yourself and you're treading very cautiously. You have to be, and like Dr. Vandana said, so the most important thing in this, no, taking the patient on your side and having the patient's family on your side and winning over their confidence and making them understand, spending few more minutes. I mean, that's easier for mental health professionals. Obviously we spend a quite a good time, psychologists and psychiatrists. But anyways, always spending a few more minutes to address all their doubts and issues is very vital. And uh, like Dr. Vandana mentioned, some of them get it couriered through one of their friends or relatives who is coming, and that is also there. And some clients of mine, actually, they have come over from foreign countries. They had planned, and one some of them planned came because the treatment was not as effective when it was face to face. So they because it needed medication adjustment, and there were several comorbidities involved. So it again, it's like you said, the therapeutic alliance is very important. They came over all the way from England for this, just they left a couple of weeks ago. So winning over their confidence and making them understand the import of the modality is very vital. So that is where ab initio, starting from the first point, we have to tell that there will be some disparity, but let's see how it goes. So we should always leave that every session or every 2 3 sessions you just kind of remind things went well, more than expected or not as expected, but still went well despite being online. But let me see how it goes further. I try to leave the scope open every time, every 2 3 sessions, so that we they should always be remembered that there is a scope for further improvement if they come face to face also. Okay. uh, that is one thing. And like, see, especially Gulf countries are very particular about I see Dr. Vandana nodding because she has been in one such country for quite a while, so she can tell more about that actually. uh, they are very finicky about schedule X drugs and sedative hypnotics. So see, they cannot persecute you, they cannot prosecute you, rather not persecute. They cannot prosecute you because you are bound by the Indian law. But again, but it's still murky waters. You don't know what lies in store. But so always be very careful about these things.
Thank you, sir. I think we're at the end of today's panel discussion, and we've talked about so much. To just quickly summarize, we've talked about the diathesis model. We've talked about what are the protective factors, what are the risk factors, what are the warning signs, and the legal viewpoint, of course. I think that's completely added in a new aspect that I think all of us trainee psychologists and psychologists in practice now moving to the online setting and the hybrid mode are going to be facing. And it's been very informative with regard to that. Um, of course, I have one final request. If all of you could give me a one-liner or a one summary takeaway home for everybody who's watching, what would that be?
I think my point of takeaway, whether it's online or offline, I think good communication, good can help to mitigate a mental health emergency. This is true for like both online and offline. And I think if we are able to direct our efforts to just have that, it helps to overcome a lot of challenges. And the family and the patient themselves can then trust us that even if there's an emergency, they come access help or try to get another way of accessing help if we are not directly available. So I think that is something that I would want to highlight again.
Yeah.
Thank you so
So
much.
to mirror what Dr. Vandana said, definitely, again, communication skills are very essential, and staying plugged into the patient's family system. Like, see, that is what we say, no, neutral, to be a active participant, but still not get affected by that. That is more. So, understand what's going on in the family and see, be mindful of the factors, what went wrong and what's happening. So so minute to minute interaction with the client. So basically it's again the communication, verbal, non-verbal. uh, so it's always good to be very observant of these things. And then Again, with like, see, it's very bad time for healthcare professionals, so doctors have to save their skin as well. So we have to be mindful of the legalities as well, so staying up to date about the legal issues, and trying to be as precise in documentation helps a lot.
Thank you,
So
sir. Yeah.
as we have to follow law of land, because we live in boundaries, right? There are human conflicts, but we understood, even I read many articles, physical distancing, emotional closeness, we should be connected well to each other, because this is pandemic time, right? So at least emotionally we are connected through online. Now we have access, so many platforms are available. Rather than saying how are you, good morning, good evening, how are you is important. So it leaves you to open up. Some, like, just good morning is not enough. So we should work together to tackle this future endemic of mental health crisis we are anticipating. Once it comes to suicide, definitely it is already set in. So we have to be well connected and strong family bonding wherever people are. It's very important nowadays.
Absolutely,
If I may,
absolutely, sir. Like you said,
if I may add one
please go
final
on, Vandana.
point, which is quite relevant, especially I think in private practice, is apart from having a very good alliance with the client, also to have a good network of professional colleagues to take guidance from, to take support from, understand how they dealt with a similar situation. Converting theory to practice really, it's very helpful to have inputs from other colleagues. So having that network of colleagues is equally important, I would say.
Right, and perhaps in an attempt to have that network, even having supervisors or peer supervisors for us in our field definitely is something that we do look up to, and that's something that helps us navigate our way. Thank you so much, all three of you, today for giving so much information and insight into such a complex topic. And I know that 2 hours is not enough to cover up all the intricacies of what we're discussing. However, we have covered a lot of ground today. We started with talking about what an emergency really means. We went ahead and talked about different kinds of emergencies that all of you have come across in your areas of expertise. We've talked about sexual abuse, we've talked specifically about children, we've talked about what to do in case of suicide management, NSSI, like Imendra brought up, and we've come across so much new information as well. And Raghavendra sir has given us so much input into how to manage those legal aspects and how doctors as well at the current day and age need to protect ourselves also along with saving human lives. And like Himendra sir did mention that we need to lobby a lot more and in order to prioritize human lives before any other legal implication, before any other thing that we look up at. And of course, we do have a lot of headway to cover in that aspect, but we're also proud of finally having a mental health care bill in our country. We're proud that we're making some headway. And of course, like it was mentioned earlier in the session, that these talks and these kind of panel discussions to help people and the general public as well to sort of come to know about these different intricacies, including students, including professionals in the field as well. And I, as a trainee, have definitely learned a lot from all three of you today. So thank you so much for pitching in and joining us today. And thank you for your valuable time.
Thank you. Thank you for
Um,
having us.
Thank, we
this
had
is
very
also
good
going to be the
interactive
Yes,
session.
sir. I'm so sorry to cut you off. I didn't hear you initially. I was just trying to say that this is the first of many series that we're planning where we bring in professionals who have so much experience, like the three of you, to talk more about this. So everybody listening, please stay tuned in to the TherapHeal page and to all social media platforms. Yeah, and that's about it. So you were saying, I couldn't hear you, sorry.
Thank you for the wonderful opportunity, and it was very nice interacting. And I learned several new things, and I got to understand several new facets of the practice that will enrich me as a clinician as well. Thank you so much.
Thank you so
Same here. Uh, Take care of yourself. Stay happy. Thank you.
Thank you so much, all. And to our audience, also, we would like to translate the same message that Himendra sir just gave. Do take care of all yourselves and to stay happy. And we are fighting tough times, so the community needs to stay in solidarity and take care of ourselves first as well.
See
We'd
you.
like to end here. So thank you.
Bye. Have a good
Bye,
day.
sir.